Welcome to Acute Conversations, the official podcast for APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect with your profession. I'm Nicole.
And I'm Leo. Today's guest is Mika Mendoza, a new grad from University of Illinois at Chicago. We discuss her acute care exposure in school and during her clinical rotations, her plans for working in acute care post-graduation,
and the importance of acute care exposure in DPT programs. Let's welcome our guest.
Welcome to the Acute Conversations podcast, the official podcast of APTA Acute Care. Today, we have our guest, Mika Mendoza, who is a UIC DPT student who will be graduating in May and is looking forward to working on acute care in the near future. Also with me today, I have my co-host, Nicole Neveau, who is going to be joining me for the podcast. Welcome, both of you.
Thank you.
Hi.
So, Mika, before we get started in terms of asking about future details about what's going on with acute care, tell me, first of all, your origin story of how you even got into PT school. What was your first interest with PT school, and how did you discover acute care, it even being a part of our practice?
Yeah. So for getting, into the world of PT and just PT school in general, I actually was looking for part-time jobs while I was an undergrad at UIC, and I had landed a job as a rehab aide with Athletico. And actually, I was originally interested in going to OT school. However, just with working and being there for 3 years, I really, really enjoyed working with physical therapy. So that's kind of how I got into that world. And then before you know it, I was in PT school and I was doing exams and I was doing practicals and I was studying a lot. And then how I found out about acute care was honestly just through the curriculum introducing acute care to us. It's when I had met Dr. Leo as my professor, and he was talking about acute care PT and what he did and why it was so amazing. And I was like, well, maybe I'll give that a try at some point.
Maybe.
And then I landed into I'm so grateful for it. I landed into an acute care clinical along with some of our classes. What was it called? It was like integrated clinical.
Integration and assessment, right?
Yeah. And so we got to visit UI Health, which is the hospital connected to UIC. And so from there on out, I was just kind of thrown into the world, and I decided to stay because I loved it so much. So that's kind of my story with it.
Sounds like we got you on the hook.
Yeah. Yeah, it was great.
Do you have any particular stories from your acute care experience that really grabbed you in or caught your attention?
Yeah, I have a couple, like, I want to call it like aha moments, which is what you get asked a lot during interviews or even getting into PT school. Like, what are some aha moments? And for me, my aha moments in acute care were I worked with a lot of blind patients or visually impaired patients. I worked with veterans and I worked with a lot of visually impaired amputees. And I would say that one particular story that I have is I actually worked with one patient who went blind all of a sudden, no background or history of blindness at all, just all of a sudden complete visual loss. And I just remember that was my first patient that I treated alone in acute care. So there were a lot of challenges, obviously, but also a lot of learning points, and most specifically with his discharge planning and just getting thrown into rounds for the first time for that patient to really advocate for where he was going to be sent next, because we could not send the newly blind patient home to take care of his sick wife. And so
he was a caregiver also.
He was a caregiver. Yeah, he was a caregiver. He was retired. However, wife was on hemodialysis 3 times a week. So he was, the main caretaker. And so just figuring that out, finding low vision rehab places, which was an option that not a lot of people really thought of first. And so I just got really into just researching all of these rehab discharge places for the visually impaired, which I will always take with me now. And so those are some of the really empowering, rewarding, and learning heavy experiences that I had, which is why I was so thankful for that clinical.
I think what's cool is that after you've been working at a hospital for a while, you start to notice that what we do as acute care therapists is not bound by the walls of the institution, right?
Right.
And so
Yeah.
knowing like the neighborhood and knowing where your patients are going to be discharged to and knowing what resources are available, I think it just arms you to be such a better prepared therapist and to be able to help out with that overall discharge plan, right? Like knowing, okay,
Absolutely.
what are the low vision resources that we have for patients that are out there? And have you heard of this place? And it might not have anything to do that. There might not be a connection specific with the hospital, but because you were that therapist that day and you're able to provide that resources, there's a much more successful discharge plan. Now,
Yeah.
Mika, I wanted to ask you, how has your thought of acute care, how's it evolved? Because I think the majority of students that come into PT school, first of all, didn't even know what acute care PT is. And then you get a professor like myself, or maybe you get a guest lecturer like Nicole that comes in and talks about there's lines and tubes and people are sick and, you know, they're still intubated and we're going to go ahead and we're going to start early mobilization. And I feel the initial reaction is that's scary. Patients are really sick. I don't want to, you know, have an adverse reaction of the, you know, for the patient compared to when you actually went into the clinical setting in the hospital and you saw how much of an impact. So I'd love to hear how it's evolved from just first kind of introduction to acute care PT compared to now where you're chomping at the bit, you're like wanting to work and get back on the floors.
Yeah, I would say definitely. So my first year as a PT student, when we first got introduced to acute care, I would say really I took it at face value, which was like you said, really, really sick patients, like the sickest patients that you could think of attached to all these lines. And that the sole purpose of acute care that I thought at the time was to just like get them out of bed, assess their strength, maybe like stand up and send them home. Obviously, that is for some, that's the case. I would say like there's such a wide variety, which is what I learned and really saw and experienced as I continued with my clinical experiences. And it really evolved to just being exposed to a wide variety of presentations.
Mm.
And at some point, I started realizing discharge planning is a huge role. It was actually I would say my biggest key takeaway and what I really learned from just being in the clinical setting, apart from being like in classrooms. And I would also say that I feel like you really have to just be thrown in and really see all of the different possibilities. And even once you see a lot of possibilities, you're still not done seeing more possibilities. I think that's like the special thing about acute care is it really does keep you on your toes because, like, for example, with the low vision rehab, I would have never even thought about that or knew what that was until I was faced with a patient who needed that. And it really evolved too to just really realizing how much collaboration and how much interdisciplinary collaboration is key to acute care. And it's not just walking and it's not just standing.
Thank
Those
you.
those are incredibly important functional activities, incredibly important, obviously. Yeah. However, like and that's what I thought. So at first I was like, okay, we're going to go up, we're going to get up and walk. And then once you walk, you're all good. But there's still exercises that you can do at bedside. There's still exercises you can do at standing, so it's definitely is what I realized is just, it's not just walking and it's not just standing up, sitting down. You can bring dumbbells, you can bring bands.
I'm tearing up a little bit, Mika. I'm tearing up.
Look how proud you are. Oh,
Look how
Pastor Leo is so proud. Yeah, it sounds a lot, like you really connected with being able to pull in that interdisciplinary team and connect the dots for the patient and be that advocate for what that patient needed in that moment and in the beyond. And like you said, the dosage of what we're doing is so critical in acute care to really match that dose with what the patient is ready for and strategically planning the next steps, right? If I remember right, were you on the transplant floor? Is that right? Yeah.
Yes,
So
it was.
talk to me about that experience and in particular around, acute care, physical therapy, quality of life. What is that? What did you see?
I got to see a lot of different presentations from the same type of transplant surgery. So that just kind of goes to show that, treat the whole person.
Mhm.
Absolutely. Just because, there was one patient who came out of hemodialysis who like started walking 20 laps around the hospital right after versus someone who couldn't get up after hemodialysis, right? Like there's just so many different presentations. I saw a lot of kidney transplants, liver transplants. I even saw a gender change surgery that I got to work with, which was wonderful. A lot of GI transplants too, and a lot of different socioeconomic statuses, levels, health literacy levels, even like family support levels, either a lack of or an abundance. So there was just a lot of different presentations, which was wonderful to see. And I think as a student, it's so nice to be able to have that variety in the patients that you treat, just because it keeps you thinking. It keeps you from getting stuck in doing the same thing over and over again. And so, yeah, those are kind of some of the things that I saw. And it was really fun to work with all of them,
Mm.
just because I always took away from every patient that I had in acute care. There was always a learning point. There
Yeah.
was always a key takeaway. And so, yeah.
I felt when I went on my acute care rotation, I felt the day it just flew by. I started
Yeah.
after time already, and just wow, there was so
Mhm.
much that just happened with like these past like
Mhm.
3 or 4 patients in the morning. It's just, and that's when I felt like, wow,
Mhm.
this is where I want to be. Now, Nicole, I have a question for you. So ideally, like Mika would be like the perfect student that comes in and ready to learn and is motivated by acute care. But I think
Thank
we've
you.
both seen students that are
Yeah.
on the on the cuff, or maybe they come in with a preconceived notion that I'm
Mhm.
gonna work with sports. I'm gonna work with. So I'd like to hear your perspective of being a CI or just working with students that are getting their first acute care exposure. What are some things that you prioritize, and what are your kind of the important salient points as a teacher, as a CI, to kind of expose them to the acute care realm?
Wonderful question, Leo. I think, yeah, to understand my perspective, I'll have to start with just a small little story about my first acute care exposure was
Yeah.
incidentally, I had a pediatric outpatient, which is where I thought I would end up. Right? It's either sports or peds that everybody
Right.
says, right?
Mhm.
And our caseloads were low. So my CIO, well, let's pick up a few patients from the hospital. Well, I threw up on my first day.
Oh, what?
Yeah,
Keep up.
I don't
What's
know.
the
I think it
background
was
here?
like the
Yeah.
smell and the
Mhm.
sound, and I was nervous and all the things. But once after that, I kind of was like, yeah, like this is about the human. This is about the person in front of me. And whether we are caregivers working with a youth athlete after a sports injury, trying to get
Mhm.
back to their sport, you do that work because you care and you want to you're an educator to your
Yeah.
patients, you're an advocate. And then, the mechanics, the knowledge, the didactic that's behind those clinical decisions is one thing, but I really connected with the human side of it. So I think that sort of has been my mantra is like, we are humans treating humans
Mhm.
at all different levels. And we get to do that every day. And it's such a privilege. We are also amazing patient educators. I
Yeah.
would say the base of what we learn and what we're trained to do, no matter which area of practice you're in, is to educate. So when students come into acute care and maybe they're engaged with it, maybe they're tentative. I just try to remind them to keep as open of a mind as possible.
Yeah. Yeah.
We also look at what that student is what their goals are in terms of, are they looking to gain experience in and what are the operations behind this? How do we assign patients? How do you triage? How do you decide on discharge planning? And you kind of focus in on that to start with until you get them on the hook, right?
Mhm.
um, or if you have someone who's really interested in that medical complexity or connecting the dots and that interdisciplinary side, you can start by focusing there. And then by the end, you're hoping that you kind of pull it all together. I know at St. Louis University Hospital, we have yet to have a student leave and who's like, I hated acute care. I would never come back. I think we try to keep it dynamic and throw in experiences. Most recently, we started, this is really neat and got this idea from another hospital. We respond to our code strokes. Our learners do. So they go with their CI, they go to code stroke, and they get to see from door to, till that code stroke is stabilized, no matter what that may look like. And it's been an amazing experience. So I think we just try to open the minds of our students and say, whether you're going to end up in acute care, which you probably will now that you've seen all these cool things, or if you're going to go back into your comfort zone of what you were hoping for, we hope that you bring with it that problem solving, connecting the dots, interdisciplinary communication, right? All the things, Mika, you just talked about that made you fall in love with it, right? Yeah, I mean, it's great having students. Do you think you'll take students one day?
Absolutely. Absolutely. That's what I really loved about being a student myself. And I think that also speaks to just how like well organized and structured that your hospital was at with their students. Cause I think that makes a huge, huge impact. I think part of why students are apprehensive or, kind of iffy about going into acute care is just because it's so new. Like we have this expectation as doctorate students in a graduate program to be perfect and like already know everything. I myself was nervous. Like my first week, I was like, I don't know if I can do this. I have no experience with doing this, but that's exactly the point of why you're there, right? Like, so I think it makes such a huge difference when, as like a clinical program, you make sure your students know that they're there to learn. They're not there to be perfect. You want to expose them to as many things as you can in a safe manner for them to really learn and enrich their experience. So I think that sounds like a great clinical program. I would have loved to go and see stroke codes. That would have been really interesting.
Nicole, it's funny that you bring up if Mika's gonna take students in the future. So they just had their departmental award ceremony. Like that's the PT program on Friday. I know Mika's laughing because she knows what I'm going to say. On Friday, they have their, like the whole college, like OT, PT, and all of the other different colleges still have their official graduation. But they did superlatives, right? And for example, who out of the class is most likely to open up their own business? Who most likely is going to be president of APTA? Mika won an award. She got the award of most likely to come back and teach over at UIC. And so,
I did too.
Right? I think you're such a good spokesperson for what acute care can be like and what the experience and being an ideal student of seeing that these are learning opportunities. And not all the clinicals were acute care. You had like outpatient, then acute, then outpatient again. But you like really learned as much as you took as much as you can in terms of a learning experience and excelled in all those situations. Now, Mika, I have a question for you. So I remember learning stuff on the didactic realm of things, right? Like you learn about post-stroke. If it's in this part of the circle of Willis, they're gonna, this part of the brain is gonna look like this. And like you just memorize it. But when you see it, you're like, wow, this is frozen into my memory. And so Nicole, you had mentioned these students that see a code stroke, really what a stroke look and what that assessment looks like that's frozen into your memory forever. The first time I saw a lady that had true neglect and she had no idea. I'm like, do you not realize you're sitting on your hand? It's like, we learned about this, but to see it, it really resonates. Mika, do you have anything that you remember that you witnessed? You're like, wow, we learned about this, but now seeing it with my own two eyes and being a therapist, that's here. It really is stuck in your mind.
Yeah. I would say one thing that, we learned about it and we practiced it a lot for like during our labs was when you guard a hemiparetic patient and what assistive device you would use, right? Like you would ask us like, okay, what assistive device would you use? What's the best, guarding strategy? And so I remember learning about that in didactic. However, when I was presented with that in the clinic, but not all things were as straightforward as we had learned it in didactic, right? I had a hemiparetic patient at one point. However, there were a bunch of other complications as to why we couldn't use certain assistive devices. And I had to get a little bit more creative. They did have neglect. However, there were just a lot of other factors. I honestly can't like bring it out into my head, but My key point from that was, when I actually saw it, one, I could feel how difficult it was because, as much as we we tried to act as the hemiplegic patient in the classroom, you're always, you don't know what that experience is like.
Mhm.
So having, a full grown patient who's hemiplegic, like really lean on me, it kind of really showed me like, wow, this is like what it's like to really hold the patient up, giving like max assist and blocking the knees. So I feel like that was when I was like, oh, it's tiring. Like you don't realize how tiring it is until like after you've seen the real thing. And also taking other things into consideration, like we had to use a hemi walker instead of like another assistive device, or we had to have a chair follow, we had to do a Sarah steady, all that stuff. So just putting it all together and really experiencing it and your body experiencing that was a whole new level of learning that I just don't think didactic is able to teach. So yeah.
All those
So
tubes and wires. Like where do I put this? What do I do
all
with
the
this?
tubes
How do
and
I
wires.
hold this and this all at the
Yeah.
same time, right?
Yeah.
Yeah, that actual like hands-on skills side of it. And then I think what you were just saying about the resiliency of humans, right? Going
Mhm.
back to that, we are humans treating humans and the weight of that and what that means. And like people do things you just don't expect, right?
Yeah,
Oh, you're sitting on
absolutely.
your hand. I didn't expect that. But also you mentioned it earlier about the transplant patients. You're like, you had a transplant, less than 20 hours ago and you're running around the unit,
Mhm.
just the
Yeah.
resiliency. It's amazing.
Yeah.
It's funny, Mika, you mentioned about how tired
Yeah.
sometimes you'd be. I have to give a shout out to my colleague, Dr. Aubrey Little. She said that on her acute care rotation, she would literally, after coming home from the hospital, she'd walk in the door and just fall to the floor and just,
Yeah.
just take a nap and just being sad. Because
Yeah.
you're right. As much as we can try to simulate things, or when you're practicing with your classmates, it's not the same. That's why I feel like sometimes when I get to play the patient, and I can somewhat act it. I can really show you what it feels like if I'm not using my left arm or my left leg and
Mhm.
how the difference is. But when you're working with your classmates, it's it's just not the same.
Yeah. Yeah.
And the
And there's
risk
no
isn't there, right?
Right,
yeah,
right.
yeah, exactly. And there's no like, okay, now you're supposed to like put your hand here. Don't move your hand. Like in the real clinical setting, it's like, I've had patients who like all of a sudden were like whipping an arm out or, getting very short of breath. So there's just a lot of unpredictable variables
Yeah,
there.
for sure.
So yeah.
Speaking of unpredictable barriers and arms flailing, what was your experience in terms of, healthcare worker safety and knowledge and what did they cover with you as a student and what do you take away from that? I mean, obviously you still want to go into acute care. So that's a great thing. So how do we what's your opinion?
In terms of the actual healthcare workers' safety, to be completely honest, I feel like what I've learned most in that regard is actually through a lot of the patients that I treated who were healthcare workers and were coming in because of a breach in their safety in the hospitals. I personally myself too have seen aggressive patients and where things have kind of escalated quickly.
Mhm.
Mhm.
There are, what I learned from that is there are set precautions like in the hospital room or in the hospital itself, right? There's restraints, we had security walking around floors that had certain codes on them, like for the whole day.
Mhm.
So I never really got sat down really and said like, okay, this is, you know, what you do when this happens, or it's really just when it does happen, then we kind of learn, or my CI is always there. Someone's always there really to
Right.
take you as the student and be like, okay, here's what you should do. At least like, at the hospital that I was at, it was really great and a supportive environment. I was never alone. But, I did have like patients like threaten to throw an IV pole at me or something like
Yeah.
that. And this is not to scare any of the students. This is not to scare
No?
any of the students, but that's the reality of it. And
Yeah.
sometimes you have to really take a deep breath, assess the situation, what's the real risk of emergency, and also just see where the patient is coming from and then just, call someone. I feel like no man is an island in acute care. So
Yeah.
you'll always have support from all the professionals and the security measures there. So
Yeah.
yeah.
Those are some great points, and love that you weren't ever alone. I feel like that's true across the board in all of acute care. Like, you're not alone, right? And
Yeah.
and you get to, we don't force people, right? So if they're not able and willing to do that in that moment, and that doesn't mean that we hold it against them in the future, right? And we'll just let them have that moment and back off.
Yeah.
Yeah, absolutely.
Although it's funny because now, like, from the didactic teaching portion, it's like, how do you prepare students? Like, we can talk about it, but it's just so cool how many skills that need to be developed to be a successful acute care therapist, right? Compared to Mika, if you can just think about when you first started your acute care rotation compared to at the end, and that was only 12 weeks. Imagine what your future looks like, the amount of skills. And when you see a very seasoned clinician kind of work their magic, right? So like Nicole, you brought up a good point. Like, we're not going to force patients, but those seasoned clinicians, they know how to negotiate, right? And how to like bend the rules a little bit here or there. It's like, well, we're supposed to start at 10:30, but I can go see another patient. I can come back, and after you watch your episode of The People's Court, and then I can come. The patients are all watching the most horrible TV show. Then why are people watching? But a seasoned clinician is so good at like being able to negotiate, right? And customer service. I was talking to someone the other day just about like the customer service aspect. And Nicole, you bring that up. It's like, we're working with people. We're not working with just productivity numbers, and we're just trying to, like, sell widgets or get as many units. And I feel that the therapists that really understand that this is a person-to-person connection, we have to establish this connection, and then we can move forward, right? Those are the ones that usually have a lot of success. Which brings me to this next question: is that a lot of students or a lot of programs don't require an acute care rotation, right? And I feel that that's wrong. I think that should be necessary. And even if it's just small exposure, maybe it's not a full long rotation, but I feel like not exposing students to that sector of physical therapy is a disservice to their education. So I just wanted to get both of your opinion. What are your opinions? I think, we might be a little bit biased, but why is it important that students get that exposure to what an acute care setting looks like? Even if they come into PT school, I'm working with only athletes. I'm only working with, this set of outpatient patients. Why do you think it's important that we get at least some exposure to that acute care setting? I'll start off with you, Mika.
I know it's hard to, I know personally, like, for our program, right? Like, we only got 3 full-time clinical rotations. So it's just hard sometimes when you have like 60 students who need to all get placed. There's requirements for like a complex setting.
Yep.
However, I still think it's so important for acute care to be a part of that, or at the very least, like some sort of inpatient setting, just because, I think now that we've turned PT into a doctorate, right? So it's attesting to how our knowledge is expanded, like how much we know about all the different diagnoses to such great detail. And I feel like having students go into an acute care clinical rotation, I think it's just so important because you will never know if you don't try it, right? Like you miss 100% of the shots that you don't take. And I think it's the same with acute care, especially because there are so many things that get debunked when you're in an acute care clinical rotation. And so I think it's just a good opportunity for people to get a chance. And if you still don't like it, that's completely fine. But at least you can say that you tried it, and you'll still always learn. Like, I guarantee, like, you'll learn something, whether it's more understanding of people's economic statuses, whether it's understanding, how to respond to an emergency, which can definitely still happen in outpatient and all of these other settings. I think that it's just, I don't know, I am biased, but I think it's just, if more people have the experience to be in an acute care clinical rotation, I think that just ups the chances of more people going into acute care, right? So
love that.
Yeah.
Nicole,
those are, I mean, I think you touched on a lot of great points. Based on my own personal experience, I will say that if we require all students to go through acute care, we'll have to give them a puke bag, right? Because it's gonna happen, right?
Part of the equipment.
And I don't say that to scare anybody, but we do. I think you have to be mentally prepared when you enter into an acute care setting for being able to see the fragility of life. In the basic functions. But I think that's where the reward in it comes in, is also seeing the resiliency of life, and getting that dichotomy in practice and the only way you can really see it is to get into that acute care setting.
Mm-hmm.
Interestingly, I just spent some time with Ethel Freeze.
Oh, yes.
Right.
Mm-hmm.
And this conversation came up. So I have to credit her with this, but it really struck me is saying, if you're going to go into home care, you really ought to have acute care experience.
Yes.
Home care is really an extension to the hospital these days, with shorter length of stay and more simple complexities. And I thought that was just such a great point that she made. Yeah. So I do think it would be great logistically if every student could have a clinical rotation in acute care. I understand why we don't in this moment, but maybe that's a call out to our universities to say, if you don't have a lot of acute care clinical rotation selections for your PT students, maybe at least build some bridges to get those students over there for observations or, just time in that space, so that they can see what does it look like when a patient is sick. And maybe the vitals show you that, but maybe not, maybe they just feel really bad, and they might show up and they will not might, they will show up in our outpatient clinics.
Exactly.
It just, something doesn't look right or doesn't feel right, and in sort of how to know, like, we're going to have to react to this. So I think it would be great if everybody, of course, I'm biased too. I would love if every student had an experience in acute care, whether it's an afternoon in the ICU or if it's a 12-week rotation like you had, Mika, just to, get that spark and see. Maybe you do love it. Maybe you don't need a puke bag forever. It's just the one time, I promise. Because I'm overwhelmed with excitement for being in this room helping a patient go to the bathroom.
Yeah, I definitely had skipped lunches during my rotation at some point.
And I've heard of students like passing out or even just like the smell of alcohol. There was some type of trigger that just created that syncopal episode where that occurred. You said there's a call out to the universities providing those opportunities, but I feel this is a good opportunity to make a call out for those clinicians that are out there that are not CIs in the acute care setting. We need acute care CIs and fantastic CIs that are able to provide these learning opportunities for students, again, because there's so many students out there that said, well, I had no idea what acute care was, and then I had this fantastic CI. I saw them and how much of an impression they made in the healthcare system, how important the role is of an acute care PT, and how they were able to help navigate a patient through these difficult times. And after seeing that, for them to be motivated to say, hey, maybe acute care is a profession that maybe that's the sector of PT that I want to practice in. So this is a call out to those CIs that are out there and those possible CIs. I do know, I was working a couple of weeks ago and I was talking to the OT director at this hospital who takes care of the OT director of student placements. And she said, like, a lot of the OTs are burnt out and they don't want to take on the students. So I would ask those PT CIs out there, please, we would love the opportunity to give the students for them to see acute care, because again, I think what we do is awesome. And we're kind of holding this back and not giving them an opportunity to witness how great PT can be in the acute care setting. So thank you, Mika, for sharing your story.
Attention members, APT Acute Care is currently seeking nominations for the 2026 elections. Open positions include Vice President, Treasurer, Practice Chair, Membership Chair, Nominating Committee Member, Residency and Fellowship SIG Vice Chair, and Total Joint Replacement SIG Vice Chair. Nominations close on June 20th, with elections slated to open in August. See link in the show notes to find out more information. And now, back to the show.
I think it's time. We're about time here. I think it's time for rapid responses. So, Mika, you know how this goes. We're going to ask you some rapid fire questions. I'm going to provide timer up. We're going to set this up for a minute. You're just going to go ahead and give us the first thought that comes up in your mind when you set up the timer.
Okay.
And I will start off with the first question. Mika, are you ready?
Yes.
Okay. And go. Mika, tell me, what kind of shoes do you wear on acute care?
Not white ones.
No, good. Excellent.
Okay. Mika, rock, paper, or scissors?
Rock.
Rock.
Yeah.
Cool. Mika, tell me, what's your most favorite season? Winter, spring, summer, fall?
Winter.
Winter, all right.
Do you think that we should ban polo shirts?
No. Yeah. Yeah.
Yes?
Yeah, we should. We should.
I think you have one on, right?
Yeah,
I have my
do.
polo shirt right now.
Yeah.
Mika, are you an Apple person or an Android person?
Apple.
Apple.
Mhm.
Are you a morning person or a night owl?
Neither. I'm always tired.
Well, life of a PT student.
Yeah.
You're almost there. You're almost there.
All right, and we're at time. So last question, Mika.
Mhm.
You know you're working on acute care when, complete the phrase.
When you try to swipe your badge to get into your house.
Right?
I've done that so many times. I'm like, why isn't it working? My eyes are closed.
It's like your brain is so maxed out from everything that you've seen in the day. You're so tired. You walk and you're like,
We've all done it. Don't deny it.
well, Mika and Nicole, thank you so much for being here today for this episode. And Mika, good luck to you. I know that
Thank
you're
you.
going to be graduating. You're looking for an acute care job. So if there are any employers in the Chicagoland area and you would want to have a fantastic employee,
I'm your girl. Yeah.
Come on.
and if people are in the St. Louis area and they would like to work in the acute care setting, you can contact Nicole, who works for SSM. So,
Yes. It's been a wonderful opportunity to connect with a lot of different professionals from different states. Like, you never know when I'll relocate, right? So,
True.
so
True.
thank you so much.
Yeah,
Well, thank you again. Thank you, Mika, for being here. Thank you, Nicole, for being my co-host for today.
Absolutely. Anytime.
Awesome. Thanks, everyone.
We would like to thank Mika for joining us on the podcast with one of our new co-hosts, Nicole Neveau. Acute Conversations is the official podcast of APT Acute Care. This episode was hosted by Leo Arguelles and Nicole Neveau, executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APT Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for an engaging conversation with Kim Levenhagen and Trisha Healy on the new APT Acute Care Aspire and Achieve Mentor Program. Thank you for listening, and may your shoes and scrubs stay clean today.